Hello, my name is Michelle.
And I am Nicole.
And we are dental hygiene students at Lake Washington Institute of Technology. Our research presentation is on the efficacy of periodontal therapy in preventing periodontal disease in diabetic patients. The objective of our project was to research our PICO question. For a patient with diabetes, will quarterly visits every 3 to 4 months, as compared to biannual visits every 6 months, decrease the likelihood of developing periodontal disease?
Periodontal disease is chronic inflammation and destruction of the underlying supporting tissues of the teeth, which consist of the cementum, gingival tissue, ligaments, and alveolar bone. It's characterized by gingival inflammation, pocket formation, loss of connective attachment, and alveolar bone resorption, which will result in tooth loss. It has several causes, such as inconsistent home care, genetics, diet, and systemic disease. Diabetes mellitus is a chronic disease that is characterized by hyperglycemia, which is elevated blood glucose, due to a defect in either insulin secretion by pancreatic beta cells, a decrease in insulin sensitivity, or it can be a combination of both. Inflammation is a central feature in both diabetes and periodontitis. It's been shown that inflammatory processes are upregulated in the periodontal tissues of patients with diabetes. Controlling glycemic levels in patients with diabetes is the key issue, and it has been shown to cause clear effects to the oral health, specifically regarding the periodontium. Because the periodontium is consistently undergoing constant wounding from bacterial biofilm, there can be micro and macrovascular damage done to the tissues. Diabetes results in delayed function of immune cells, specifically the neutrophils, monocytes, and macrophages, which can cause further damage to the periodontium. It's been found in these patients that neutrophil adherence, chemotaxis, and phagocytosis are often impaired. This enables bacteria to persist further in the periodontal pockets and to significantly increase destruction of the periodontium, in addition to increased apoptosis.
The methods we used for our research were primarily done by conducting searches on healthcare databases, such as PubMed, EBSCOhost, ProQuest, and Cochrane Library. We use keywords and mesh terms such as periodontal disease, periodontitis, diabetes, diabetes mellitus, prevention and control, therapy, inflammation, blood glucose, and insulin. We then further narrowed down the search by using the filters peer-reviewed, meta-analysis, systematic reviews, and additionally, we restricted the dates from 2003 to present. The following were results in patients with controlled diabetes or prediabetes, those with a glycated hemoglobin or A1C from 5.7 to 6.4%. In a 5-year cohort study of subjects, a total of 96 with controlled prediabetes who were originally periodontitis-free revealed that 32.3% developed periodontitis at the end of the study. In a study on alveolar bone loss in Pima and Papago Indians, aged 15 years and older, with diabetes, a group with prediabetes, and a group with normal glucose tolerance, subjects with type 2 diabetes had an increased risk of destructive periodontitis. There were no differences found between subjects with impaired glucose tolerance. In a Japanese case control study that examined 664 male military subjects, ages 44 to 57, and classified into 3 groups: normal glucose tolerance, impaired glucose tolerance, and newly diagnosed diabetes. There were no significant findings between impaired tolerance and bone loss compared with normal glycemia. There was a positive association between type 2 diabetes and bone loss. The following were results in patients with uncontrolled diabetes, those with a glycated hemoglobin or A1C greater than 6.5%. In a study of uncontrolled diabetes, 88 Gullah African Americans were followed for 1.9 to 4.1 years. All non-third molars were probed at 6 sites for a total of 9,648 sites. Subjects with A1Cs greater than 7% had an increase of probing depths of greater than 2 millimeters. That's a significant progression compared to those with A1Cs of less than 7%. A 5-year study in Pomerania found that those with A1Cs greater than 7% were at a greater risk of periodontitis than those with A1Cs less than 7%. The risks were 4% higher for developing new clinical attachment loss of greater than 5 millimeters, 36% greater for losing any teeth, and about 60% greater for losing 2 or more teeth. A Japanese study with 5,706 participants found that those with A1Cs greater than 6.5% had a 17% higher risk for developing new periodontitis over 5 years, which occurred in 2,068, about 35% of that group. Panoramic radiographs from 359 Pima Indians were scored for new alveolar bone loss occurring over a 2-year study period. Results showed that those with A1Cs greater than 9% had an 11 times greater risk for developing new alveolar bone loss than the subjects with normal blood glucose. Those with well-controlled diabetes were not at a higher risk for bone loss.
In conclusion to our research, we discovered that chronic periodontitis has been identified as the 6th complication of diabetes, alongside retinopathy, nephropathy, neuropathy, macrovascular disease, and poor wound healing. Because we also looked into older studies, we found that they concluded that there is a strong bidirectional relationship between diabetes and periodontal disease, which were found to be consistent with the more up-to-date research discussed in this presentation. Given the results of our research, we found the risk for developing periodontitis is directly correlated to the patient's A1C score. Those who are considered to have prediabetes or controlled diabetes, whose scores are less than 6%, do not have a significant increased risk of developing periodontal disease. However, those patients who have poorly controlled diabetes at scores greater than 6% are at an increased risk of developing periodontal disease. While we were unable to find detailed studies regarding whether quarterly dental prophylaxis treatment was more beneficial in preventing periodontitis in diabetic patients, we did find that routine dental hygiene appointments improved these A1C scores. Because diabetes and periodontal disease have a bidirectional relationship, this does suggest that more frequent maintenance appointments could be beneficial in both controlling the patient's blood glucose levels and possibly preventing or controlling periodontitis. While the evidence we have leads us to presume this course of action would be beneficial to our patients, in order to fully answer our PICO question, further scientific study would need to be required.
And here is our references. Thank you for watching.